My name's Josh Logan. I'm a urologist in Anchorage, Alaska. I was diagnosed with bicuspid aortic valve with minimal aortic stenosis when I was a fellow at UCLA in 2013. Started on annual screening echocardiograms that remained stable for about a decade, and then had significant progression and was told that I should start thinking about having surgery. And my wife and I started looking around to figure out where and how that should be done. And through our research, we found Dr. Johnston and had a consultation with him. And he heard about my story and heard about kind of the lifestyle that I have. And I live in Alaska for a reason. We do a lot of time in the backcountry. I'm out on boats in the ocean, fishing, backcountry hunting, backcountry skiing, mountain running. I could either have a tissue valve, which would have meant no long-term anticoagulation, but the trade-off is I would need another valve procedure likely at some point in my life, or I could be one and done, but the cost was having to have lifelong anticoagulation.
We did discuss a couple of other options for treating the aortic valve in younger patients, in particular the Ross operation, which involves taking the pulmonic valve and placing it in the aortic position. The downsides of that, as we talked about your expectations for the operation, number one is a full sternotomy versus the other options that we could do with a minimally invasive approach. So for people who really want to get back to activity, that's a trade-off that we need to discuss. Important to note that most of this conversation took place with you in Alaska and me in the US. Continental US. So we didn't ask you to travel here for a consultation visit. All of the prep work was done. Any studies we could do in Alaska were done in Alaska. You were sending your echoes. We looked at the progression over a short period of time to decide what the timing was. But all of that preparative discussion, what are your options? Where can we go with this? What surgical strategy can we employ? What valve choice? All that was done remotely.
Post-op care was smooth as well. Stayed in town for a few days afterwards to make sure everything was okay, and then transitioned back home, transitioned my care back to my local cardiologist, and have had annual follow-up with Dr. Johnston.
There are a lot of excellent programs around the country. It's patients who want the smallest possible incision or the fastest recovery on one end of the spectrum like you, and people with more unusual conditions or complex conditions like reoperations. We talk to a lot of patients who have already been set up for a great intervention by their home team, and we talk to people who've only been told one option when they were 4 or 5, and that's where really having that conversation with the patient is key. And very common scenario, somebody your age being told you have to have a mechanical valve. Well, that would have been totally inconsistent with you riding snow machines or out hunting in the backcountry. It sounds like that worked out because you were able to go out and break some bones.
One of the things we like to do in the winter is snow machines. I think most people call them snowmobiles. You don't call it that in Alaska. But flipped mine over this winter, landed on an ice road, broke my shoulder, so spent the first 6 months of this year rehabbing that. That's a great example of a situation where I would not have wanted to been anticoagulated. I'm blessed, I'm grateful to be able to have this level of care, and for you guys to be so responsive and ease of communication. I know you guys strive to provide that to anybody and everybody you come into contact with.
That's absolutely what we hope is going to be the experience. And we know with any diagnosis there are always bumps in the road, but if you have a team that you trust and you can have somebody you can get a hold of quickly, then we can always take care of those things. So it's great to see you doing so well.
Yes, sir. Thank you.